Alrighty, good afternoon or good morning, depending on where you're located. Thank you for joining us today in a live webinar presentation on compounded low-dose naltrexone hosted by CareFirst Specialty Pharmacy located in New Jersey. My name is Dr. Choi, and I'm a final year pharmacy student at Rutgers University. I developed this presentation on a general overview of low-dose naltrexone or LDN to address frequently asked questions while patients are taking LDN. I also have Chuck, one of our pharmacists here at CareFirst, right next to me. He is helping me with the presentation and will be answering any questions from the audience later in the presentation. Before we begin, I just wanted to let you know that a digital copy of this presentation is available for download. There's a link in the info panel. You can click to show more and expand the panel. And the recording of this presentation will be available from our YouTube channel in case you need to come back to this later. So today we are introducing an overview of how naltrexone works and what it is indicated for, as well as other potential uses of LDN. We will also discuss relevant safety information about potential side effects and notable drug interactions that you should be aware of while taking LDN. Then we'll go over available formulations for compounded LDN here at CareFirst Specialty Pharmacy and wrap up the session with the open Q&A where Chuck will answer any questions that you type into the chat throughout the presentation. We have prepared a pre-recording of the slides and we will meet you at the end of the pre-recording. If you have any questions throughout the presentation, just feel free to type in your question to the chat. So let's begin.
What is naltrexone and how does it work? If you are familiar with naltrexone, you may have heard that it is originally used for treating opioid-related disorders. This is true, as naltrexone is a pure opioid antagonist, meaning it blocks the action of opioids, like heroin, which is an illicit drug, and other narcotic pain relievers, such as morphine, oxycodone, hydrocodone, and fentanyl. If you take a look at the naltrexone structure on the right side of the slide, it resembles the structure of morphine to a great degree, with the exception of three spots: hydroxyl group, ketone, and a cyclopropyl group. What naltrexone does is it goes to opioid receptors, specifically to the mu-type receptor that is believed to have effects on causing euphoria, sedation, and addiction, and binds to the receptors while giving no room for real opioid molecules to bind to, and ultimately blocks the euphoric and sedative actions of opioids. This process is called competitive inhibition. This process is quite slow. It takes at least 1 to 2 hours as naltrexone typically binds to the receptors first, before blocking the action of opioids. In contrast, another opioid blocking drug, naloxone, acts faster by knocking off opioid molecules that are already bound to the receptors. Since naloxone is a faster acting drug that acts almost immediately, generally within 5 minutes. Naloxone spray under the brand name Narcan is given to someone who is under a life-threatening condition due to opioid overdose. On the other hand, naltrexone is commercially available as intramuscular injections under the brand name Vivitrol, as well as oral pills that are also available as generic. Now that we have talked about how naltrexone works in our body, we can talk about what naltrexone is used for. Traditionally, naltrexone is prescribed for the treatment of substance dependence, like opioid drugs or alcohol, as part of medication-assisted treatments. For the opioid use disorder, naltrexone is used to reduce craving. Once a patient starts taking naltrexone, the patient feels less urge to get opioids because naltrexone blocks the euphoric effect as well as the additive effect of opioids. One thing about naltrexone in opioid users is that it requires a complete washout period of at least 7 to 10 days, up to 14 days, depending on what type of opioid they were taking. As naltrexone acts by blocking the actions of opioids, it does not prevent or treat any withdrawal symptoms like agitation, anxiety, muscle ache, insomnia, or increased secretions. In fact, if someone takes naltrexone without the washout period and there's any opioid molecule circling inside the body, naltrexone could cause or worsen withdrawal symptoms. So, it is critical that patients remain opioid free for the duration of washout before they start taking naltrexone. Moving from the traditional uses of naltrexone, there are recently proposed ideas about using naltrexone at a lower dose. From the previous slide, oral naltrexone for opioid use disorder and alcohol use disorder requires around 50 to 100 milligrams daily. Nowadays, researchers came up with an idea that if we use naltrexone at lower doses, like around 1 to 4.5 milligrams, we could use naltrexone for more conditions other than substance use disorders. So, if you remember from the previous slide that naltrexone blocks the action of opioids, including euphoria, sedation, and addiction, by blocking opioid receptors, naltrexone also inhibits the analgesic function, or pain-relieving function, of those opioid painkillers. It may sound confusing. Wait, if this drug blocks the analgesic function, how does it make sense? The idea is that if we inhibit opioid receptors, our body would release more anti-pain and anti-inflammation substances. Originally, without naltrexone, our body depends on a baseline level of hormones and neurotransmitters that are involved in managing pain and inflammation. But as we add naltrexone and block the body receptors for these baseline neurotransmitters and hormones, our body recognizes it's not getting usual levels of endorphins and dopamines signals. Then, our brain produces more endorphins and dopamines as a compensatory mechanism called upregulation. Additionally, LDN inhibits inflammation by blocking TLR4 receptors and the downstream nuclear factor Kb signaling cascade. With the increased production of these hormones and the blockage of inflammation pathways, we could expect better control of pain and inflammation. And there are a wide variety of areas that many practitioners have prescribed low-dose naltrexone for, such as multiple sclerosis, inflammatory bowel disease, Crohn's disease, chronic pain, and so on. We start LDN at a low dose from 0.5 milligrams to 1.5 milligrams daily and increase gradually to 4.5 milligrams daily or higher as needed. This is because we want to avoid any side effects from suddenly taking naltrexone and stimulate the body's increased production of these hormones and neurotransmitters. Here is a summary of classifications of naltrexone based on dose ranges and their mechanisms of action. At 50 to 100 milligrams, naltrexone is indicated for alcohol and opioid abuse due to its opioid receptor antagonism ability. When given at lower doses, naltrexone begins to work as a toll-like receptor for antagonism and opioid growth factor antagonism. At even lower doses, naltrexone can potentiate opioid analgesia, therefore may help patient reduce opioid dose. Next, let's talk about safety information that you need to know about while taking LDN. While you are taking LDN, it is important to note potential side effects that can come from LDN, although LDN is generally well tolerated. The most common side effects patients report while taking LDN is sleep disturbances, which include vivid dreams and insomnia. This is due to increased endorphin release. To mitigate the problem, you can take LDN in the morning or take it at least 2 hours before sleep. While it is rare, upset stomach, including nausea, vomiting, constipation, and diarrhea, may occur while taking LDN. This happens because LDN blocks a large number of delta-type opioid receptors in the gut. Again, naltrexone blocks opioid receptors that are present in the brain, CNS, as well as in the periphery, GIT. You can avoid this by taking alternative routes of administration, like sublingual formulations with which LDN does not need to go down to the GI tract, but instead is rapidly absorbed through oral mucosa. You can also try taking LDN with food to reduce GI complications. Naltrexone could also cause liver toxicity and increase liver enzymes like transaminases, which you may have heard of as AST and ALT. But this is relatively rare with LDN, as liver toxicity is quite dose-related, and you would be taking a lot less amount. If you have underlying liver failure or other types of liver conditions, make sure to consult with the doctor before initiating LDN. Also, if you are planning to take LDN and you are currently taking opioid painkillers, make sure to follow the washout schedules. Otherwise, LDN could increase the risk of opioid withdrawal syndrome. There has been a report of an initial increase in fatigue and spasticity in multiple sclerosis patients. These symptoms look like a flu and worsen over the first 2 to 3 months. While in most cases, these flare-ups would disappear after the first few months. It is something definitely you need to keep an eye on and discuss with your prescriber if it doesn't go away. This is not an exhaustive list of every side effect reported, and these could be other side effects that are less likely, but you might still experience. If any of these other side effects are still bothersome, have a conversation with your prescriber for many different ways to reduce these side effects, including going back to a lower dose by 30% to 50%, then coming back up. This slide is to just give you a list of drugs that could interact with LDN, and therefore should be avoided while you are on LDN. Opioids and alcohols are a no-go with naltrexone, as we just talked about how naltrexone is used to treat alcohol and opioid dependence. This includes any synthetic opioid painkillers like tramadol, Ultram, and meperidine, Demerol, and those opioid agents like methadone or buprenorphine, which are used for medication-assisted treatment or detoxification. Other types of medications that interfere with opioid receptors are Imodium and Lomotil. These laxatives antidiarrheals only interact with opioid receptors in the periphery, mostly in the GI tract. But naltrexone can have its effects in the whole body and may interfere with these opioid-type laxatives. If you are taking it on a regular basis, avoid taking extra doses of these laxatives. Other medications like immunosuppressants, cancer drugs, and those used to treat advanced diseases need to be discussed with prescribers. While most biologics and some low-dose steroids under 20 milligrams equivalent of prednisone may be continued, as long as they are stable and continuously monitored. Next, let's take a look at details on dosing and available formulations of LDN. Like many other medications, LDN dosing is individualized based on the condition and side effects. LDN is usually started at low doses, ranging from 0.5 to 1.5 milligrams daily, taken at night, followed by a titration period every 1 to 2 weeks, where daily doses are increased by increments of 0.5 to 1.5 milligrams, until the total daily dose reaches 4.5 milligrams. Depending on prescribers and patients' conditions, higher doses above 4.5 milligrams may be used if they're necessary to better control symptoms. Again, if any side effects happen or if you are not able to tolerate LDN at a certain dose. You can ask your prescriber how to manage it with different ways to take LDN. Here at CareFirst Pharmacy, we offer a variety of formulations for LDN. This includes liquid with oral syringes, capsules, and tablets with various strengths, sublingual formulations for patients with upset stomach, and topical creams. Additionally, we can provide different filler options if you'd prefer LDN or any other compounded medications in capsules. Your prescriber may specify a certain type of filler to be used, or sometimes you have the option to choose which filler to use. We're almost headed towards the end of the presentation already. Before we open up the table and answer questions we received in chat, let me give you a one-page summary of important points that I'd like you to take away from this presentation. LDN could take up to 2 months to start having clinical effects. So, it is important that you continue taking it as directed by your prescriber on a regular basis, even if you feel that you are not getting any immediate benefits right away. But if you feel like you're not getting any better, even after waiting for 3 months, definitely talk to your doctor to change the doses or find alternative options to treat your condition. Finally, if you are currently taking other medications other than LDN, or if you need to take other medications in the future, know what you are or will be taking. Inform your doctor because they might interact with LDN.
Alrighty, that was the end of the slide with pre-recording, and now we'd like to hear from you. If you haven't, please ask any questions about LDN, and our pharmacist Chuck will go over questions from the chat momentarily. And Chuck, if you're ready.
Thanks, Dossel. Great job setting up this presentation. I'm Chuck, one of the pharmacists here at CareFirst Specialty Pharmacy, and I kind of just wanted to maybe recap quickly because I'm looking at the questions here. I might be able to answer them with the recap, and then we'll go into a couple of these specifically. The way I understand it, naltrexone for a while has been available commercially at strengths from 50 milligram and higher. And what normally we've seen is it's used to block the effect of opioid painkillers and opioid type painkillers like tramadol competitively. At the very low doses that we're making here, compounding, it basically seems to have an effect at sensitizing these same endorphin areas. And so there's side effects kind of associated with that. We get feedback on, say, vivid dreams and also GI disturbances. That's because there is opioid receptors in the GI system that can get sensitized. So that's a possible side effect that's associated with low dose naltrexone. Also, we do get feedback that some people experience headaches. Uh, what we see a lot of prescribers doing is they will titrate to effect in order to get somebody at a comfortable dose where they can tolerate it. As far as the benefit, we see a lot of it prescribed for diseases that are associated with, say, autoimmune. There's a whole litany of them in that category. And basically, the way we understand it is naltrexone at these low doses blocks some type of toll receptors that have an effect on cytokine levels. Cytokines cause inflammation, inflammatory processes. And over a span of time, up to like say 7 weeks or plus, you do reduce the inflammation by taking the naltrexone, and hopefully it helps with some of the symptoms associated with diseases that are in the autoimmune category. So I'm trying to read some of these questions. They're great questions, and I'm hoping I'm catching it just with some of the overview. We did have one question. Let me start off here. We have what's the difference, and this is what kind of I mentioned in one of the first slides, I believe. How does naltrexone work different than like say Narcan, um, which is uh, naloxone. It works different because naltrexone, it's like a pure opioid antagonist. It kind of blocks the action of opioids. It literally kind of competitively inhibits the effect of strong opioid type painkillers, including tramadol. At the low dose, I mean, at Narcan is a more of a it knocks off the opioid molecule that's already bound to the receptor. So it kind of can reverse the effect of opioid use. That's why it's used for, say, opioid overdose. It also works fast, inside 5 minutes. So that's kind of like a difference between those two. To go over that again, there's a question here that I read. It has to do with somebody needing to come off of naltrexone because they say have a surgery coming up. Right. It'd be one of the ones you would stop. You wouldn't have to worry kind of about retitrating to start up again on the naltrexone. You want to stop naltrexone at least 24 hours prior to needing to take strong opioid type painkillers. All right. Low dose naltrexone, it's got it's immediate release, and it's got like a 5 hour roughly duration of use at the low doses. At say 50 milligrams, I thought it was. I think it's more like 24 hours, but it's dose related. So we're compounding between zero point 0.5 and 4.5 roughly, lower or higher. To uh, to go back on naltrexone after you are off of strong opioid type painkillers, we would like to see a wait, say 5 to 7 days after the completion of those type of painkillers before you want to start up on say low dose naltrexone again. Like I said, you don't have to kind of retitrate. You just kind of start where you left off prior. Let's see what else we have here. Somebody asked about the benefit of sublingual naltrexone. And yeah, we do make a sublingual tablet. We also do it in a suspension. The tablet we do is in 3 or in 4.5 milligrams. And the benefit of the tablet is you get less GI absorption. So you hopefully get less of the initial stomach, or should I say, squeamish feeling you could get, or nausea and vomiting that can be associated with the PO formulation, or the oral formulation of the naltrexone. Taking it sublingual, let it dissolve under the tongue. Um, Also, it may last slightly longer because I believe the tablet goes through first. It's got a first pass effect through the GI, so you're kind of circumventing that too. So you might get a longer um, duration of use out of a dose. So that's that question. Let's see. A question we have with prednisone use also with naltrexone. Like prednisone it's also anti-inflammatory, but it doesn't work the same as naltrexone does. It works by different mechanisms. So I'm not sure if you can you know use one or the other. I mean, they can be both used together. There's no that I know of any real drug interactions. You might want to think about taking it with food though, because prednisone can cause some stomach irritation too. So it's probably best with food. But no, it doesn't replace prednisone. Um, what else do I see? Is low dose naltrexone proven to stop inflammation and progression, joint pain, joint damage or joint pain? It's used for we see it used for rheumatoid arthritis, and like I said, it would take a span of time for it to start working, up to about 2 months, um, for you to start seeing a benefit. But how that would work, that would fall like an autoimmune, and you would hopefully decrease the inflammatory chemicals by blocking the toll receptors, reducing cytokines, and over a span of time, maybe reverse the effects that are associated with that disease state. To answer that question. Um, yeah, there's some very, very good questions in here, and it's hard for me to get to them all. Is there any kind of conflict with gabapentin? No, you could take right. Gabapentin, we see them both used concurrent. Like gabapentin is used for like neuropathic pain, and right, and so it's good. It's going to work differently than how naltrexone is going to work. So we do see that uh, that combination prescribed together, say gabapentin or something along those lines for neuropathic pain. They would be used together without too many problems. Um, so look, these questions are great. Please give us a phone call here at CareFirst Specialty Pharmacy. We're at 844-822-7379. We're available between 9 and 6 Eastern Time to answer these questions. We have pharmacists staffed during these hours full time. So anyhow, it's been a pleasure answering your questions, and Vassal, great job on this presentation, and we hope to hear from you soon. Give us a phone call. Thank you.
Thank you very much. Once again, thank you everyone for spending your time this afternoon or morning to join our live webinar, and I hope you have a great rest of your day.